Welcome everyone to a conversation exploring idioms of distress as part of the African Academy for Migration Research, hosted by the African Centre for Migration Society at Wits University. It gives me great pleasure today to invite three wonderful women who are researching different aspects associated with idioms of distress in Kenya, Malawi, and South Africa. We have with us Dr Christine Musyimi, who is a researcher at African Mental Health Research and Training Foundations in Nairobi, Kenya. Her work promotes excellence in community-based mental health research with a focus on depression, intimate partner violence, and dementia, and improving maternal and child mental health to increase access to care in remote settings. We have Dr. Edna Bosire, a medical anthropologist and currently postdoctoral researcher at the Georgetown University Center for Innovation in Global Health and the Kamuzu University of Health Sciences in Malawi. Edna has published widely on HIV, diabetes, mental health, and nutrition. We also have with us Emily Mendenhall, a medical anthropologist and professor at the Walsh School of Foreign Service, also at Georgetown University. Emily's published widely at the intersection of anthropology, medicine, and public health. And her most recent book is entitled Unmasked: COVID Community in the Case of Okoboji, which is Emily's hometown in the USA. I'm really looking forward to the conversation, and thank you once again for joining us. Okay, so welcome everyone, and thanks for joining us today. Today we're going to be talking about idioms of distress, and I'm delighted to be joined by three fabulous women who are working on various aspects linked to issues around exploring idioms of distress. So what I'd like to do is invite each of our guests to briefly introduce themselves, where they're currently working and their key research interests, and then we will move into a wider conversation. So first of all, perhaps Edna Bosire, you would like to introduce yourself and your work?
Yeah, thank you so much, Joe, for this opportunity. My name is Edna Bosire, and I'm a medical anthropologist. I finished my PhD from University of Witwatersrand. That is PhD in public health and medical anthropology. And my research interest really focuses on patients who have HIV, type 2 diabetes, mental illnesses, and also issues to do with nutrition, both for adults and adolescent nutrition. So during my work, of course, because I work closely with patients with chronic diseases, then I've been able to explore and learn and even unpack or uncover issues to do with idioms of distress, where patients really narrate how the idioms of distress are related to their diseases and also other socioeconomic factors that we'll explore later. So currently, I'm a postdoctoral scientist for the Blantyre Prevention Strategy for Georgetown University, and I'm based in Blantyre, Malawi. Thank you so much, and back to you, Joe.
Wonderful, thanks so much, Edna. And if we can next move on to Christine Musyimi. Tina, over to you.
Thank you, Joe. Hi, everyone. My name is Christine Musyimi, and I'm a researcher at the Africa Mental Health Research and Training Foundation. I focus on addressing gaps in depression, intimate partner violence, and dementia, as well as addressing maternal and child mental health in community settings, specifically in Kenya. Specifically, my research interests are around developing context-specific interventions while taking into consideration the culture and language interpretations of specific idioms or specific terms that will have an effect on the community members in regards to discrimination, in regards to stigma. So my interventions are focused on reducing stigma mostly, while trying to increase access to care in community settings.
Fantastic, thanks very much. And over to Emily Mendenhall. Emily, if you would like to introduce yourself and your work.
Yeah. Hi, everyone. It's such a privilege to share some virtual space with some of my favorite people. So thank you for inviting me, Joe. This is really fun. I'm Emily Mendenhall. I'm a medical anthropologist. I study a lot about kind of culture and mental illness and how people experience living with chronic illness or cumulative trauma over the life course and what that looks like. and how people experience and think about illnesses that maybe they haven't thought about before. Recently, I've been working on COVID, which is really interesting, especially in rural Iowa and in the United States. But I had the privilege of first working with Edna and Tina in 2014, when we were doing a study with the Africa Mental Health Now in Training Foundation. They switched their name a bit. But this is where some of the earliest work took place. So I'm very excited to talk about that work with you all today. So thanks.
Fantastic. Thanks, everyone. And it's lovely to be able to chat to a team of researchers who've obviously worked extensively together, but also bring different perspectives, different experiences, and different sort of focus areas together. And I thought maybe to sort of kick us off is we could perhaps, sort of some basics to help us think through this is, some of your, your reflection on what are idioms of distress and why is it so important that we engage with the language of idioms and the ways in which idioms of distress play out. And within that, a particular question and something that we explore in other parts of, training around migration and health, for example, is thinking about where understandings of culture fit in here and perhaps mediate our understandings and engagement with idioms. And I wonder, Edna, perhaps we could start with you and for some of your reflections on that. Thanks.
Yeah, thank you so much, Jo. And thank you for this wonderful opportunity, because it helps me reflect back to the number of patients or participants that I've interacted with, as I mentioned, participants with chronic diseases. And these participants use different languages or use different, emotions to describe when they are stressed, when they are suffering, when they are in pain. And this is something that I've realized from Kenya to South Africa, now to Malawi. You find that there's different expressions that people use to explain how they are feeling. And they relate it to the body, to the pain they have in the body, what we call somatic symptoms. So what I've realized is that these expressions are very important, which might really be lacking in the medical diagnostic tools or equipments that are used to measure or to diagnose symptoms like depression or stress, because some of these words are really linked to people's culture, as you mentioned. They are linked to people's way of life. They are linked to people's belief systems and so on and so forth. For example, what we did in Kenya, as Emily mentioned, we did this study trying to understand people's lived experiences, social experiences with depression, with diabetes. And we found people used a blank word of kufikiria sana. Kufikiria sana is a Swahili word, which means thinking too much. So this thinking too much, people really used it to express how they were feeling. And they divided this into two categories. We have the word huzuni and we have the word dhiki. Huzuni is basically used to refer to like depression. It could be linked to depression, which is a scientific term known for depression or diagnosis of depression. But then we had others using the word dhiki, which was rarely used, but people will talk about dhiki to try to show like they are really saddened and all those facts. So coming down to South Africa, people also use various words to describe, feeling sad, feeling stressed, feeling depressed. So what I can say as a start is that these words are very important to understand how people pattern, how people categorize their illnesses, and what factors, what even influences them to categorize what they feel. Is it because they have other comorbidities like diabetes, for example? Is it because they have other social issues like lack of food at home, or even gender-based violence, or even the social challenges, hardships that people go through? So these are very, very important. Idioms of distress are very important for us to understand, for researchers to understand, for students to understand, and then to see how do we ensure that all these are captured in clinical management of patients. Thank you so much, and over to you.
Thank you. I think, a fantastic overview, and I think particularly, as you say, the importance of, if you're working in a clinical or a biomedical setting, being able to engage and understand, somatization, idioms of distress, and the ways in which different approaches and cultures around lived experience, social experience, result in things being labelled in particular ways, and what that means for working in diagnostic spaces, if we want to use that biomedical term. I wonder, Tina, is there anything you'd like to add on to that around why in your work it's so important to be engaging with local idioms?
Yeah, thank you, Jo. I think it's very, very important to understand that different cultures have different expressions of idioms of distress. And these expressions are related to how they understand themselves in terms of experiences of distress or experiences of affliction. And so it's important because it reveals how individuals experience symptoms of that illness in their local understanding, in their local dialect. And in most cases, the local idioms reflect the causes of the illness or a precursor to actually, or rather a warning sign that requires someone to seek treatment. Because, for example, the local interpretation, for example, the local idiom for depression, as Edna mentioned, thinking too much. If look at someone or someone mentions that they are thinking too much, that's already a reflection of a warning sign that someone requires treatment. Because while you're thinking too much, there's a lot of that is happening. Probably you're not talking about it, you're just thinking too much. And when someone is looking at someone is thinking too much, they're probably not talking about it. The last way of expressing it is maybe a relative or a carer who says that my friend or my family member is actually thinking too much. So that's already a warning sign that something is happening. And so we need this local idiom so that we at least have a clue of the type of illness that is affecting populations and what kind of illness or what kind of experiences our communities are experiencing, so that it leads us to a certain condition or a certain disease that might not be reflected using the the medical terms within the either DSM-5 or the formal forms of assessment that are readily available and maybe not accessible by the local populations.
Thanks so much. Before we sort of move on a bit, I wonder, Tina, you mentioned the DSM, and I wonder if you could just briefly explain for people what the DSM is.
So DSM is Diagnostic Statistical Manual for making a diagnosis of various various psychiatric disorders or mental health problems. And so it gives a systematic process, an algorithm of identifying clinically if someone has a particular form of mental illness. It is usually used by clinicians, and it has not been certified to be used by non-specialists, but there are already various forms of assessments. For example, the Mini Plus, which is a bit simpler and illustrates the different ways of identifying an individual with mental illness without necessarily having to undergo a whole training on psychiatry.
Now, I just wondered, sort of linked to that, whether, this is where I suppose some of the sort of conversation about the importance of understanding idioms, particularly within a biomedical setting, is I wonder if any of you would like to reflect a little bit on this DSM approach versus local expressions of lived experience and so on. And one issue that I think might be linked to that is also thinking about whether you've got examples of the ways in which individuals might make use of a specific illness to discuss their own idioms. So almost the other way around, if that makes sense. So through a particular illness, discussing idioms. And I'm not sure if anyone would like to start there, and then or Emily.
I can speak to that a little bit. I wanted to make a note about our work in Kenya, because I think something that Tina brought up was really interesting is, first of all, psychiatric categories defined by the DSM are, these static categories that don't apply to everyone. They're categories to diagnose and treat and care for people. And these categories are exported around the world and don't always map right onto people's real experiences. And that's why taking stock of idioms of distress matters so much. And one of the things that I thought was so interesting about our paper in Kenya is that thinking too much and the symptoms of thinking too much mapped around how people used local terms like huzuni, which some interpret as depression, but people really define as a specific type of grief and deep pain. So it's this type of depression that doesn't map onto all social experiences. And then we also found that, which was really interesting, is people were using English terms of stress and depression in specific locally defined ways that weren't really relevant to the DSM, for example. So when people would be like, I'm depressed, I have depression, it was more of a way of feeling blue and down and linked to kind of a difficult experience, but it wasn't like a diagnosis. So people had used kind of clinical terms that people had been expressing and sharing and redefine them in their own context. So in some ways, these terms became their own distinct local idioms in our study in Nairobi, which was really useful to know, especially because thinking too much was actually used as a symptom across all, with huzuni, with stress, with depression, in every single way, in different ways. So thinking too much, which is the most common idiom of distress across the world, which makes sense because when it's really expressing some sort of rumination and often physical pain in the back, neck, sometimes head, people are really focusing on something difficult, right? So thinking about how people use thinking too much across these different other categories of expression, I think was really interesting, and really revealing of how people experience difficult things, and really useful.
Thank you. So, yeah, I wondered, if there's any other reflections, Edna or Tina, about this sort of disconnect, between the DSM and the language of idioms, whether there's anything, in your work. I'm always intrigued about how, medical practitioners, for example, who rely on DSM sometimes really struggle to engage with things like idioms. I just wondered if you had any reflections on that.
Yeah, so I'll just jump in to give a typical example, like when a patient presents to the hospital and the clinician engages with the patient, and there are some descriptions. The patient might say, maybe I have headache, or I have stomachache, or I have, my temperature is high. So, all these, they are used as a standardized way to categorize people's, diseases. For example, you might say, okay, these and these and these symptoms, maybe they are directing me to malaria, for example. So if there's need for a patient to test for malaria, the same approach is used for mental diagnosis. And that is why, as anthropologists or researchers who are trying to understand the issues of culture and diseases or illnesses, really have a lot to contribute, because as I mentioned earlier, even these words, as much as you might see a lot of literature written about thinking too much, this varies across context, they vary across culture, because someone might say, I'm thinking too much, but if you see the expressions that they are showing thinking too much might vary across cultures. Someone might relate it to the head paining too much, or a heavy head. Someone might, like what we found in Kenya is like having a heavy heart, or the heart, ringing or crying, or there's some sound. But when you go to people like in Zimbabwe, for example, they use it to show like a lot of thoughts or a lot of thinking in the head. And when you go to communities like in Uganda, you find thinking too much is mostly related to social issues, or a husband losing a job, or even, having orphans who are left because their parents died of HIV. And the same kind of a pattern is realized in South Africa, but they keep on shifting, they keep on changing. And when we talk about thinking too much, or someone trying to show their own idiom of distress, sometimes it's also transferable to the people who are caregiving to these people. For example, if someone has a chronic condition, someone is managing them. So the person who is sick, we call, like the sick person here might express they are thinking too much, but someone who is taking care of them might actually inherit this kind of thinking too much. They might also start overthinking on behalf of this person or other social relationship around. So for me, I see it as a very, very important contribution. And that is why we see the gaps in the biomedical frames of trying to assess and even diagnose some of these mental health conditions. And that is why we say we need to really ensure that these idioms of these traits are also included in some of these, like DSM-5, for example, and of course be adapted to fit a particular culture and a particular context. Thank you so much.
Thank you so much. Tina, is there anything you'd like to contribute to this?
Yeah, thank you. Just to add that what my colleagues Emily and Edna have shared is very important. And there is really lack of studies and matching validity studies on local idioms of stress expression. And so there needs to be just trying to match the local idioms with a certain psychopathology is just not enough to achieve validity. So there needs to be lots of methodological rigor or research to try and do validity studies on local idioms of distress will actually with real-time psychiatric diagnosis, so that even when we are trying to put these kinds of local idioms in standard forms, then they are locally appropriate and they've gone through a certain way of scientific rigor.
Thank you. I mean, that brings me to, if we look specifically at your 2019 paper, looking at ethnopsychology of idioms of distress in urban Kenya. And Tina, you just mentioned this term, ethnopsychology. And again, I wonder if that's something you or Edna or Emily would like to sort of define for us, because I think it's something, again, this idea of bringing together ethnopsychology, we're talking about idioms, we're talking about diagnostics, and that sort of, blurring, as it were, and ways of understanding and exploring experiences. So yeah, I wonder, I mean, Tina, would you like to pick up on that again, as you've mentioned it?
Thank you, Jo. I think I'm probably not the best person to answer this when we have ethnographers on the team, so maybe it's an idea to give credit where it deserves. Maybe Edna and Emily could give that you'd be in a position to answer that.
Emily, please carry on.
Okay. Really kind of the complexity within a local context and how people define kind of the realm of psychological experiences. And I think this paper is such a good example, because by looking at thinking too much and looking across the way the kind of rumination, the thinking was expressed and embodied, people talked about how they felt it, how they experienced it, and how they linked it to different expressions that were both locally and biomedically defined and then experienced. So thinking about the full expression of how people convey and experience and think about their own psychology is really important, because there are very clearly prescribed psychometrics and psychiatric disorders for which people can get care, but people are not often speaking about their experience in those terms. So thinking about it from a cultural perspective, how are people thinking about things that will be called PTSD or depression or anxiety? And these categories really matter, because that's how people get care, especially for severe mental illness or neurological issues, psychosis, really getting medical care or medication is so critical. But even getting in the door for psychotherapy or other care is, you really need this diagnosis in some ways. And, I'd love for Tina to also talk about some of the work that they do on really innovative mental health care and, non-medical care too, thinking from working with faith healers or other local leaders in providing medical care, because the work that they do in Nairobi is really important and not static. They look at the whole kind of life course and do a lot of different innovative care, research on care and training too. So.
Fantastic. I mean, that's a great, thank you so much for that, Emily. And I think, that's a nice sort of segue into talking a bit more about responses and the more practical side of, how we can, as you were talking about sort of the need for this research to inform improved responses. And Tina, if you'd like to share a bit more specifically around, obviously the work in Nairobi, that would be great to hear. Thank you.
Yeah, thank you, Emily and Joe. So we've been doing lots of work engaging traditional and faith healers. And definitely this category of healthcare, let me call them health workers because they are not integrated within the health system. They are not trained, but use the skill of apprenticeship to be able to train possible future traditional and faith healers. In some cases, faith healers fall into the category of deacons, pastors, or even imams, and these are in churches or mosques. So we use this kind of lay workers who are in touch with the community, who understand the cultural perspectives of these community members. They are trusted, they are respected, and these are the people that actually have the heart of the people in the communities. So we normally use the skill that is already existing and introduce conventional treatment in terms of psychosocial interventions and train them because they already have the skill in terms of creating rapport with their patients or persons who come to them for any kind of treatment. So while we understand that their cultural beliefs in relation to, or negative attribution to witchcraft when it comes to even mental illnesses, and we are not talking just about depression, but we are talking about several mental illnesses, depression, dementia, and all these illnesses are attributed to witchcraft. So we really acknowledge the specific cultural beliefs within the community and try to use the providers that exist within these communities and train them on more conventional ways while trying to incorporate the cultural perspectives or the cultural attributes of when it comes to accessing care and intervention. So this is work that we've done over time, and we've realized that traditional healers and faith healers can actually act in terms of psychosocial treatment, can actually provide treatment over time. In one of the studies we did around depression, traditional and faith healers provided psychosocial treatment to their patients, and over a period of 3 months, there was significant change, about that 4% significant change was observed among patients receiving treatment. So just to mention that neglecting them or putting aside or treating them in a parallel system is not a solution that we need to know, but acknowledging that most of the people with mental illnesses actually go to these providers, and understanding the cultural interpretations is very, very important in developing interventions.
Super, thank you so much. And Edna, is there anything you'd like to add to that from your side and your experience? I was wondering in particular if there was anything that's particularly related around nutrition and diabetes, HIV that you might want to reflect on.
I just wanted to echo what Tina said, especially having patients going to these non-informal carers. That is the first, definitely, we say that is the most, the first step that patients take when they are sick. They either get care from within the house or start with those local networks before they even make a decision to go to the hospital. And I've seen scholars also argue that this approach of using community health workers and faith healers or even traditional healers is a cheap way of providing, it's like cheap medicine for poor people, which I really dispute, because I've worked with like Tina and other people who are really engaging these informal carers. What I wanted to say is that they serve a very important point, and they serve a very important cause. As Tina said, these are not clinicians, but they are trained to offer some basic, basic roles like referrals to the hospital, and also trying to assess if that community, remember some context, these diseases, mental health diseases are very stigmatized. In some states, you won't even know that we have a sick person in that house or in that household. So having these people, these are people that are trusted within the community. So having them, they really play a big role to ensure that they are able to communicate with clinicians and also do some few basic psychosocial support to these patients. So moving to the question you asked about diabetes and maybe nutrition in relation to idioms of distress, So what I've done a lot in South Africa is to try and come up with interventions or come up with recommendations that are trying to promote cultural competence and structural competence. Remember, Tina has talked about engaging with these informal carers or health workers at the community level, but then we don't need to just concentrate at that level. We also need to go to people who are making decisions about the patients, people who are designing care for the patients. So are these people able to understand the patients? Are they able to understand the cultures of these patients? Are they able to understand the resources that these patients have? So as anthropologists, we try to drive the agenda of the clinicians must be able to understand the people's socio-cultural or economic context where they live, even as they design care for these patients. And also some patients might have a comorbidity. For example, they might have diabetes and HIV, but having comorbidity, having physical conditions might actually be a recipe for having a mental disorder like depression. For example, people might be so tired of taking care of these chronic diseases, and that can promote stress or depression. But the patients can also start with a mental health condition, and then it might also lead to a physical comorbidity. So we try to understand this interrelationship, you know, the relationship and the clustering of these diseases at the community level. That is what I can say, and that is what we've done a lot in South Africa with Emily. But lastly, maybe, I don't know if you are coming to this, so we are now moving beyond the idioms of distress to idioms of resilience. Because as much as we talk about distress and resilience, these people, the patients who have these attributes, they still flourish in their context. They still, I mean, they are able to overcome some of these challenges. So I think maybe I leave it at there. If you want us to talk more about this, or Emily might jump in later about this. Thank you.
Great, thank you. Emily, I mean, it would be great. I mean, I like this idea of coming to the conversation around idioms of resilience, and we can always come back to that. But is there anything you'd like to contribute, sort of following on from this conversation about, you know, interventions, and whether there's any other context that you might want to sort of reflect on? Your work in the US, for example, might be helpful to hear a little bit about as well. Oh, you're on mute.
Sure. I'll speak just actually about our South African work, because this is kind of where some of that innovative work was coming from. And Edna and I've been working together for like 8 years now, and on multiple projects. And so I'll talk about our piece on idioms of resilience. We were working with breast cancer survivors, and just kind of asking about how they manage, and, you know, kind of the words they speak about where they get strength, and, you know, how they define health and well-being. You know, looking at how people were speaking about resilience. And we found that a lot of, and this is actually something medical anthropologist Durga Sengamworthy has written about as well in the US among African-American women. But the women we were working with from Soweto, who were seeking care at Bera for their breast cancer in the South African breast cancer study, were really talking about this kind of radical acceptance of their experience. And there's an anthropologist, Sarah Lewis, who has, whenever I talk about resilience with her, she always talks about that resilience, and her work is with Tibetan Buddhists, which kind of makes sense for how she thinks about resilience. But you know, it's not, you know, doing well in general, but it's like doing well in spite of challenges, doing well in spite of adversity. Because it's never you're doing great or you're doing terrible. People are always, all humans across the world have their own challenges, and especially women who've survived breast cancer and have, you know, other things. So often women we were interviewing had other comorbidities. So this was specifically in a clinical population, which is different than the community. But women were really talking about this radical acceptance of their experience, and kind of moving on through that strength, and that knowing that, you know, things move forward, and I can do well. And also, you know, reliance on family, and you know, knowing I have someone who loves me, and also like knowing that the clinic is there for me. You know, these kinds of ways where women were really talking about, you know, what gives them strength amidst this kind of a difficult thing. And then Edna and I have also been involved in this big study across the community. And one of our colleagues, Lindy Leigh just led a paper on flourishing. So she was looking at how people define flourishing locally, and kind of how they defined and understood what it meant to live a good life and to have good health. And in many ways, and the paper actually just came out like yesterday, or Friday. So she really defined this piece because when we were studying chronic illness, she was asking people about their experience and, stress and illness. And they're like, well, let me tell you about what it means to do well and what it means to have good health and live a good life. And so people were using the word kufumelela, which means, kind of becoming victorious, to overcome. And so we were working with anthropologist Sarah Willen, who's done a lot of work on flourishing, and we kind of came in conversation, and Lindy led this project where, people were really defining it in terms of Ubuntu and in terms of how people define the self and success in relation to others, and to what it means to live a good life and have good health was also involved, so much of the social. Which, is really, really important work in defining and so often left out of clinical conversations.
Yeah, thank you so much. And I think, I really appreciate this, the idea of sort of, idioms of resilience and the importance of when speaking with individuals about like their health experiences and health narratives, that it isn't always about the negative, and the importance of acknowledging and understanding, as you say, where forms of strength, forms of resilience. And it's interesting to hear, for example, that the clinic was a space seen as a positive space, and, reminding both, healthcare workers, healthcare users, and society more broadly, that in the context of struggling public healthcare systems, they still play an incredibly important role in supporting care. And I do think that sometimes is overlooked through the research questions we might ask, which sort of brings me round to, I'd like to sort of see if we could focus on this for the end of our conversation, but is really thinking about your experiences of doing this research, particularly when we're thinking about, the ways in which, as an individual doing the research, perhaps not from a particular space, perhaps the languages being used are slightly different, what it means for navigating and understanding certain idioms in your own context, and then engaging and learning about idioms in another context. And I'd love to hear some of your experiences around that. I don't know, Edna, you've worked across these different spaces, so perhaps we could start with you. Thank you.
Yeah, thank you, Jo. And that is really a very interesting question, and I was looking forward to it. Conducting a work or research in Kenya, because I'm a Kenyan, it's easier for me to resonate with some of these idioms because I've lived them. I've grown where people are. It's something that I know, that I've always grown up to understand. But then moving to other contexts, definitely there are going to be gaps. And as an anthropologist, that is the beauty of it, is that I'm trained about relativism and also being reflexive, and also not being able to, carry my own imposition and my own biases while interpreting other people's cultures. So what has happened to me is that I've worked closely with the locals. For example, coming up with my question guide, interview guides, engaging with people in the units, like in South Africa. Emily talked about Lindy. Lindy is one of the person we've worked closely with, and other researchers in the unit who've helped us to, try to understand, even to try and frame questions in a culturally sensitive way and something that is acceptable to the community. And that also helps me to learn some of these things, and also to understand why people use certain idioms the way they do, or why people live certain ways. I've also been able to move to community spaces where people live in Soweto, for example. And what I've done, I've not just gone there by myself. I've always had a research assistant who understands the local language. So what I appreciate most is to ensure that, if possible, these interviews can be conducted in vernacular languages, and the most commonly language, for example, the isiZulu, so that we are able to get the rich meaning of what participants talk about. We'll end up doing transcriptions and doing translations, but we also engage with people who are able to understand both languages That is the local language and the English language. So I know as a researcher, I might go with my own biases, but we try to ensure that we try to engage with the local people. We get the meaning as they mean it themselves, not as I see it as an outsider. Thank you so much. Wonderful, thank you. Tina, is there anything you'd like to add around your experiences?
Yes, definitely. And just to what Edna is talking about, I think for us, when we are having discussions, we have lots of participants expressing their opinions and feeling like they're sharing a story in discussions. Some cases, yes, you have a guiding set of questions, but our discussions sometimes go past, 1 hour, 2 hours, even 3 hours, because participants use the focus group discussions or the key informant interviews as, sort of therapy sessions, and they want to actually express themselves as a way, to share their experiences and better help others to cope with situations. So for us, we do not limit the interviews, because once we disconnect someone who is actually expressing a sort of distressful situation and we cut them off in this process of guiding questions, then we are likely to miss out, on patient or participant needs. So what we normally do, we just make sure we allow the participant to express their views, and finally, maybe during transcription, we just pick what is relevant. And from feedback from participants, we've had participants saying that, thank you for the training, thank you for the treatments. People feel like focus group discussions or key informant interviews that we conducted are a form of therapy sessions. And for us, we are usually open and usually put in some spare time, because in African settings, or rather, let me say specifically in Kenya, when people start talking about a story or start telling a story, then there's no structured way of doing it. You just tell a story until you finish your story. You can't tell someone to give a story in 30 minutes of 1 hour. So that way for us, we've been able to flow with the participants, and people have been able to share freely during discussions. The other thing that has allowed free participation is, for example, if we are conducting focus group discussions and a participant says, I would prefer if you engage me at an individual level or a personal level rather than in a group, we are very flexible and usually allow that, because these are sensitive discussions, sensitive topics that we are usually discussing with them. And so we are flexible when it comes to that, because at the end of the day, we are looking for expert opinion or experiences of people with lived experience, expert, and we call them experts because they already experienced the journey of the illness. The strategy that we use is also engaging stakeholders or other gatekeepers who give us permission to get to their communities. And because, again, they are trusted, and whatever they bring into the community, it is assumed to be, factual or impactful in the community. So the participants usually trust them. And so we use this opportunity so that we get a buy-in from the gatekeepers as well as from the community. So, and in the process, try to explain to them the purpose of the study, the benefits that they're likely to, get from the study, as well as the risks. Even though we might not be doing an intervention, what are the risks that the participants are likely to experience? And then once we are done with the study, we always have a dissemination forum where we tell them what we found out and disseminate these findings. So we've not had major challenges. The only challenges we face is when participants do not have to do not feel comfortable participating in focus group discussions, but we normally have an option of participating either in key informant discussions or individual discussions.
Wonderful. Thanks so much, Tina. And I think, you're touching there on various sort of research ethics, right? And the issues we need to think about, and sometimes the tensions, where a participant, indicates after an interview, thank you, this has really helped me. But as a researcher, we're not necessarily there as a trained counselor or therapist, but the benefit that is received versus concerns that, for example, you know, a research ethics committee might have about assuming that this is an inappropriate approach, right? Because the concern that will a participant perceive this as therapy, rather than a participant has agency and can choose to engage or not. And if through that process, many of us find conversations cathartic, right? Sharing a story. So thank you so much for sharing that. Emily, any reflections your side on sort of some of the challenges and the sort of successes of this kind of research?
Sure. Well, because you asked me to talk about my recent work for a minute, so I'll do something. So Edna and I have been doing these. She hasn't talked about it yet, but Edna did the study on COVID in her hometown, and I did a study on COVID in my hometown. And let me first talk about kind of my approach as an anthropologist, for example, in our study in Kenya. A lot of anthropologists do this lone wolf anthropology where they go and they do this long term ethnography and do a lot of solo writing and research and independent work. I don't really work like that. I'm much more collaborative, and especially in this study in Kenya, like I was there for, I was there for 4 months. Edna worked with me for a year. Gregory Amondi and Gatonga Isaiah, they also were working with us for this long period of time. This was an iterative process. We were all team members, and they were really leading. Like I was on Gatonga did all of the consenting and all of the kind of blood work and some other logistics. And Edna and Gregory Amondi, they were doing all of the in-depth interviewing. And Edna, how long was your longest interview? Like 4 hours? Mm-hmm. I mean, they were taxing and long. And so we were really working as a team. And I was on site for a while, but the weird foreigner just staring at people in the corner was really pretty annoying. So what we ended up doing is I would kind of stop by maybe weekly or whenever it was useful or they needed me. But Gatonga was like, he is incredibly organized, and he had it all. We were on WhatsApp constantly, but he just basically had everything organized. And every Friday we'd have a long lunch where we'd meet for like, how long? Edna, 2 or 3 hours, where we'd kind of go through the week and talk through ideas that were emerging, maybe say, we need to talk about this a little bit more. We need to talk about this. But our team was really in synergy, and we all had different roles, and we were all equally valued. At least I would say, and I don't know, I hope everyone felt equally valued. But this was in a language I didn't speak. It was, my first book's Endemic Suffering, and it was in Chicago. I speak Spanish, and it was pretty lone wolf, actually, much more so. And, it was a dissertation project. So it was that's how a lot of them are. But this project was just really great because I wasn't the expert. I was part of a team. Even though I had, and anthropology is so cheap. Like I had such little funding. It basically paid the salaries of my colleagues and paid for the blood samples. But it wasn't one of these big studies. And, Africa Mental Health and Training Foundation does these really big studies too, these big evaluations. And, I was small banana, small compared to a lot of the stuff that they do, but the whole team was welcoming. I often met with Victoria Mutiso and Professor Ndete, David Ndete, who were so welcoming, and the lead of the organization. Routinely we would touch base, and and Tina was so welcoming, and we were constantly in conversation. So this work was just collaborative. It was all engrossing, and we were all in conversation all the time. So that was, and Tina has like 25 hats at the organization. So she wasn't even involved in some of the early work, but because of our ongoing conversations, we knew we needed her expertise, and she's done all of this work on idioms of distress and mental health care in general across the organization for so many years, and is, really central to the organization. So, so that's kind of maybe overly explaining how that project was done, but it was just super collaborative. And I learned so much, and it was really fun, and the team was really fun, and we get to have lunch, and that was always really great. So that's kind of how I work. I've worked in South Africa, and I did a postdoc in Delhi, India, where it was kind of a similar, every place you work is a bit different, but kind of similar way of thinking. So I just did this study in my hometown, which was like very ethnographic, a lot of observations. Like I interviewed 100 people, but I went to a ton of social forums, and nothing was related to a clinic, but it was observing. I mean, there was a lot of rumor and a lot of, just, a lot of chit chat and gossip that what I, really dug into to get to the heart of the story. It was really funny because, when you're an outsider looking in, you hear all of these things, but, you're trying to put all the pieces together from something that your family isn't a part of. So I would love to hear what Edna has to say about her elderette study, because she also worked with her sister. And in my study, so I just wrote this book, Unmasked, COVID Community in the Case of Okoboji, which is the name of the town I'm from. But it basically is kind of about my brother-in-law who led the COVID response. And my dad was a city councilman. And, it's like this very personal book and this personal study. And there are just so many different things when you're really looking at the place where you grew up and where your families lived for 5 generations. The research is very different, and the approach is just so interesting. So as I'm usually the outsider looking in, this side, I was in the insider looking out, which, there's benefits to both positions, in different insights that you get from both positions. And I wouldn't say one is better or not, because you learn different things and have different takes, but it was really a fun experience.
Thank you. I mean, yeah, Edna, would you like to share any reflections on your role? And I'm interested in sort of, working with your sister in your hometown. It would be great just to, if you've got any reflections on that.
Please, would you allow me just to point out one experience before I move to that quickly?
Please.
Yeah, so what maybe anyone who listen to this audio might be wondering, because I really do a lot of one-on-one interviews with patients with chronic diseases, HIV, type 2 diabetes, cancer, that is breast cancer and prostate cancer. And sometimes it's not really easy, because you can imagine you are doing a long interview, like 3 hours or 4 hours seated in a room with a patient. Of course, they are not sick, but they are trying to tell a story of their lived journey with this disease. Some of them will break down and cry for long hours. So you have to break and even ask whether they want to continue or not, or you even reschedule. So sometimes there's an impact to the researcher or the person doing the interview that most people might not talk about. So when Emily talked about us meeting at the end of the week and debriefing, this is one way that we use to share our experiences and share with the team. And at Africa Mental Health Foundation, being a mental health organization, we had a psychologist around, so you could always, get a benefit of those services. But now moving to Soweto, we worked in an organization called the Developmental Pathway for Health Research Unit at VETS. And one thing that they really consider is to ensure that they have an inbuilt psychologist, because of the nature of studies that are taking place. So once in a while, you'll find yourself really being broken, and you need to go, and it's not about you referring the patients who feel distressed, but you as a researcher or an interviewer, you might really hold on to these experiences, and they start building up. And sometimes you find yourself breaking up. I remember when I was doing my study at Chris Hani Baragwanath Hospital, I had a story that really broke me up. After the interview, I escorted the participant out. I came back to the clinic and really cried. So after crying, I had the nurse manager was around. She came and took me to her office, and we talked about it. And as I narrated about it, the nurse also broke down. So you can see there's this experience, there's this really emotional experience that researchers also need psychosocial services. They also need to, to open up to somebody and talk about the experience and how the interview went about. So coming to, I thought that was important for me to bring it up front before we forget. So coming to my experience in COVID-19, this is a study that I just, Emily has been my mentor and always encouraging me. So we did kind of a parallel study. She did in the US, I did in Kenya. And what I did was in my local town. I'm born in a town called Eldoret. This is where I was born. This is where I grew up. This is where I schooled. And this town, it's a town that is really known for ethnopolitical violence, especially when we have political campaigns. In 2007, if you can remember, when Kenya was burning down because of political violence, Eldoret was at the epicenter of all these issues, where people were burnt in churches and whatnot. So I grew up knowing that we are living in an environment that there is always tension, there is always, the environment is not really very calm. Anytime things can spike. So when COVID hit Kenya, I thought it's good for me to see how does this pandemic then destabilize or affect the people's normal life. Remember, some of these people have just rebuilt back their businesses, they've rebuilt back their lives after previous political violence. So how does COVID affect the normal way of people's life? Is it normal life? And how do leadership, because these political violence are instigated by ethnicities and ethnic kind of political incitement. So how does it happen during the COVID-19? Do these ethnic leaders, do they come together or do they still start, it's a public health issue, it's not a political issue, but I wanted to understand the dynamics around that. And I will say the findings were really great. One of the things that we didn't expect is that there was calm in Eldoret town compared to other towns like in Mombasa and Nairobi, where we saw a lot of police brutality. We didn't see that in Eldoret. And that is the first set of study we did last year. And we are about to publish a paper on that. But we've also carried more studies in relation to vaccine hesitancy and other aspects. So I've had my younger sister helping me. She's not helping me because she's my sister, but because she's a researcher, she's a nutritionist by training, and she's also trained. I'm also mentoring her to do research. So, and other research assistants who've been helping us with data collection. And it has been a whole lot of experience conducting interviews during the COVID-19 and moving to virtual spaces to do interviews. So I think I don't have much time to talk about all these experiences, but I can say it has been a collaborative kind of experience, as Emily talked about, working with other people and especially mentoring younger researchers to come to our level, because I started from there, and I can't say I'm up there, but at least I'm somewhere. We try to help those who are now growing to also get to where we are. That will be my experience and something that I'm proud of. Thank you so much.
Wonderful. Thank you so much, Edna. And in particular, thank you for sharing, your experiences of doing fieldwork and the impact that challenging stories can have on ourselves as researchers, and the importance of finding ways to ensure we have support. And I think, when we're talking about training and we're talking about supporting next generation scholars, I mean, this is something that I'm not sure we receive enough training on ourselves, right? When we're now working and training grad students and postgrad students, how can we ensure that this is factored in and support colleagues in that spaces? So I think just to help us come to a close, I wonder if I could just ask each of you very, very briefly, one of the things we're working on is this African Academy for Migration Research, with the goal of building resources and systems and support networks to support building the next generation of African migration researchers, some of whom work at the intersections of migration and health. And I wonder, sort of drawing on your own experiences and within your respective fields of research and work, what do you think is the most important sort of take-home message that you would like to share around building your career, around training and research? What do you think it has been the most helpful sort of support to your experiences that you would like to pass on and share with other students and postgrads? Would you like to start, Tina?
Yes. Thank you. I think what I can say from my experience in regards to mentorship, I have received lots of support from my seniors. I've received lots of support from Emily, even when we were working with Edna. It's been great experience. And I wouldn't say that for upcoming researchers, because it has been my desire to mentor upcoming researchers. It's not really sort of upward, downward power transfer, but rather trying to form of a network where you're getting support or knowledge of experience from all aspects, from left, right, upward, downwards, people from the level, your mentors, and even people, your juniors, because it should be some sort of developmental mentorship where everyone is getting some sort of strength and sort of knowledge and gaining from this interaction. So in regards to the African Academy, then it's important maybe for the next generation of researchers to tap into every opportunity, and just not focus on the, transfer of knowledge from up, but from all areas in order to be able to have diverse experience.
Wonderful. Thank you so much, Tina. Edna.
Yeah, I have my mentor here, Emily, who was also my primary PhD supervisor, and I loved the kind of supervision that we had, really a very holistic kind of supervision. And I will say there was a move from pedagogy kind of approach to heutology. So it's not about an instructor-student kind of approach, but it's a kind of approach that is centered on the person, both of you, because I find it a two-way process. The supervisor or the mentor has to understand the person they're mentoring, but the person who's being mentored also has to understand the role of this person who is mentoring them. They have to understand the time they're dedicating to them. So it's a two-way process. You have to understand each other's interest. And actually, for those who are mentoring postgraduate students, I will say don't just pick on somebody to mentor somebody because you think you want to achieve that goal, but pick on somebody who fits in your own research interest, who fits in your own, you understand this person's desire. You understand where these people come from. Some of the students don't have everything. People are not equal, like students are never equal, researchers never equal. So someone who understands your background, who understands your resources, your disposition, what you have and what you don't have, and being able to say, okay, I'm happy to work with this person from this level. I think it should be from that approach, not from a pedagogy kind of approach where you find at the end of the day, there's a kind of conflict and you don't end the process well. But when you understand the person, then you want to work with them through the journey. And this person will also help you grow in some way. Thank you so much.
Thank you. Thank you very much. I mean, I think, really helpful reflections, Edna. And, while we have your mentor here, it would be wonderful to hear, Emily, your perspectives from sort of your side of the coin, as it were.
Yeah, I mean, I just think both of you hit some of the points that I was going to talk about. You're both brilliant thinking about like how you learn. It's not just formal networks, right? But also informal networks on how we support each other and grow together. I have had incredible mentors, and some of my informal mentors have been even more important, impactful. I always joke about my big sister in medical anthropology, but if I have a problem, I call on those people and ask them how to work through these challenges. And I know, Tina and Edna, you have the same thing. It's not just your formal mentor, but these people who you build alliances and intellectual and social relationships with that really you travel together with and share ideas and knowledge and, tips. One of the things that I really benefited from in these kind of informal networks is just the sharing of, okay, well, and I'm just thinking about the Institute kind of in sharing this, but, how do I do the next thing? Especially when you're like, let's say, you're trying to apply for your PhD proposal. Well, you need examples of others who've been successful, who can sit down with you and say, oh, this is the approach I took. This is how I found a mentor. This is how I approached my problem, my question, this is where I worked, and really thinking in that ways. And then, for mentors, really thinking about this as mutual experiences. Like I cannot even count the many wonderful things as through my friendship with Edna, for example, but also research. I mean, she's like, finished her PhD and she's moving on. I'm like, oh, you're going to leave me. What am I going to do? We've been thinking together for so long now, whenever we have an idea we're bouncing, we just like are WhatsApping each other. Well, what about this? What do you think here? And that I've learned so much through that experience. And I think we're always lifetime learners. That's why we're doing this work, why we love research. We want to make an impact. That's why we're public facing, doing clinically facing, public facing work, maybe policy facing work. But also we're just curious. We're all of us, here are so curious about how things work. And why things work in certain ways, and really ignoring any toxicity from people, because academia can also bring some negative things, and trying to move beyond that, and people who bring you down, just try to shift away from that and really find people who build you up. because our life is ephemeral, right? We need to build on the positivity that we make and create for each other and build towards. So that's something I believe. One other note for the thinking about migration, my first big independent research for my dissertation was with migrant women who were undocumented in the United States, and it was really about the trauma of immigration laws and experiences. But I just worked on this just a little special issue on migration with all these people who do migration, and they're like, "Oh, do you work on migration?" And I was like, "Well, I did for this one project," but I was reflecting actually on my career, and either with my teams or independently, I've interviewed hundreds of people and just spent time listening to their life stories. And I've never met anyone who hasn't migrated. Actually, like how we define migration can be so narrow, because so many people, migrate for work, maybe not far, but the dislocation from the social and the familial unit can be so jarring and challenging, financially, socially, even culturally, from one place to another within one country, right? Because of ethnic, linguistic, or just things work a little differently in different places. So thinking about migration as this broad and kind of global and just familiar experience for most people, I think is really useful. Because I found myself a lot being like, "Oh, I didn't work on migration, but I do work on migration." I don't even talk about it enough. Maybe it's something we need to really think about a little bit more, about the social dislocation and how people kind of see the self. Anyways, I'm getting into it here, but I think it's really interesting and something we all need to bring to the front a little bit more in how we do this work. So thank you.
Thanks so much, Emily. And I think really, you're touching on, maybe it's for a follow-up conversation, is about the centrality of migration and movement in much of our research. And I find particularly in the broad field of health research, right, whether we're looking at that from a more sort of applied public health space, clinical setting, from a more sort of in-depth ethnography perspective, as you say, movement is key. Moving across a city to access a clinic, that already becomes another form of movement. And one of the reasons I think that in the so-called kind of migration research field, that certain forms of movement are privileged in research. And by that, I mean that actually research tends to focus on a very particular format or form of movement and who gets categorized as a migrant, right? And it tends to be poorer people, it's class-based, it's racialized, it tends to be people who might be moving in irregular or informal ways. And we tend to have a bias in the way that our research is sometimes formulated, which potentially inadvertently contributes to the idea that migration is only about the movement of people across borders, and it's only about the movement of certain people and certain bodies across borders. And whilst in many ways that's where we need improved knowledge to try and drive improved responses, it also does mean that we inadvertently sometimes support this kind of script that the migrant is a very particular person, right? So I would love to pick that up in a follow, in another conversation with you all. I'm really aware of time. I mean, I could go on forever. This has been really fabulous, and it's been wonderful having the chance to get to know your work in more depth. So I really just want to say a huge thank you, and perhaps there will be a part 2 to come. So yeah, thank you all very much.
Thank you.
Thank you.
Thank you, Jo.